До свидания.
Так, следующий доклад, доктор Темур Душанов, наш представитель, пожалуйста.
Assalamu alaikum. Thank you for everyone, especially for those who came here from far away. So I'm Temur Duschanov. I work as an associate professor at Central Asian University and also as a practicing neurosurgeon and spine surgeon at ProfMed Clinic. So today's my topic will be focused on the beginners. As I've completed my first 100 cases, starting from the, I've moved from the skull-based and cerebrovascular surgery to a full endoscopic spine surgery. And I want to emphasize what is needed to eliminate or minimize the amount of complications, and also to reduce the complication to zero for your first 50 or 100 cases. So uniportal full endoscopic surgery, it is the same as the stenoscopic spine surgery. Of course, the benefits are the less tissue damage, the reduced reduced pain post-operation, the quicker recovery time, the low infection risks, and also the less intraoperative injury due to the high definition visualization. And also the overweight patients are not the problem. Actually, my first two patients were overweight, over 120 and 135 kilograms. So when we think about this course, like I have not failed, I've just found 10,000 ways that won't work by Thomas Edison, or by success is going from failure to failure without a loss of enthusiasm. So it is not applicable for medicine. We know that. So as a surgeons and neurosurgeons and spine surgeons, orthopedic surgeons, we know that the failure is not an option to us. So as a jet pilot, the Formula One driver, the neurosurgeon or orthopedic surgeon, we don't have the right, especially for the patient. So how to start in order to minimize the major complications in your first 100 cases, and also do not, of course, the main, in order to have the success, we have key points. I will be focused on the key points as the step-by-step guides and so on already discussed. So first is the that we should aim that we should not have complications first 50 or 100 cases. It means that the time is not what we want to think about. So the priority is quality. So even if it takes like 3 hours, 4 hours, actually my first cases was like 3.5 hours, even 4 hours. So, but without complication, it is the better way. So then you can reduce the amount of time which is needed. So, and also especially the developing countries do not broke the scope first 100 or 50 cases. So you can manage that later in your practice. And also need a minimum of necessary equipment. We will talk about in the next slide. Know which patients to operate. This is the key. I call this like super selective surgery. So you can minimize your complication in the first 100 cases. And also, if possible, you should have senior colleagues and mentors to manage the intraoperative and postoperative complications like the revisions or bleeding or any kind of issues. I was fortunate to have my colleagues like Dr. Yakubov, Rustam, Dilmurat, Kanzimov, and Jahangir, and so on. So it was not a problem in the first place in the beginning. So what we should focus is that we should be very super selective when we pick our first patients. And what we need is a very basic minimum of equipment. It is a scope, of course. It is the kerosene rongeurs. Even 2 rongeurs is enough for you, like second one and third. Then the pituitary forceps, the working sleeve, the obturator, the root retractor, and 1 nerve hook. So it is enough. And also, of course, the bipolar coagulator and 3-liter saline. So in the start, you need basic tower, the endoscopic tower, and basic C-arm, and also the long table for the nurse and the waterproof drapes. So how to select the patients? First, I think it should be like L5 to S1 primarily, because the interlaminar window is large, paracentral herniated disc, which is not really caudally or rostrally sequestrated, not sequestrated, and also large interlaminar window. The age should be like from 25 to 50 years old, so you will not have calcified discs, and also you will not have this very fresh herniation in young individuals. Like I've operated in later cases, like in 15-year-old patients. It is very difficult to operate in very fresh discs, which is has many parts, healthy parts to it. Usually it is traumatic herniations. And also you should not have revisions in the first place, of course, and also do not pick revision cases. It is for later on, and also no complicated cases like with comorbidities, with calcified discs, like multiple levels and so on. So, and also you should avoid the huge wide base herniations also. At first, I will show you, we'll discuss one patient with huge herniation, one of my first patients who had a little bit of temporary complication. So, and also you should avoid the calcified herniation and also calcifications and osteophytes. So preparation is key. We should have the recent MRI, so we can go to the surgery with very recent images, like 1 month prior to surgery. The CT always needed to be done. You can skip the CT part if you are more experienced, but first, for first cases, you should definitely have the CT, so you can assess the calcifications, you can assess the interlaminar window, the degrees of the angle of the spinous process, and so on. And you should have all of the images on the larger screen or computer while you are operating. So first 10 or 30 cases you should do, I will emphasize this, with general anesthesia to young ones, because when you explain to the patient that you will operate, you are not going to be like a very fresh spine surgeon which will do first cases. So it will take a lot of time, 3.5 hours and so on. And for example, spinal anesthesia or the local anesthesia will put a very great pressure on you when you're doing the surgery and the patient is listening to everything. So treat the patient and not the MRI. This is also a very important part. If there is multiple levels, you should concentrate on one level which is causing the symptoms. For example, one level, L4, L5, it is in another side, the L5, S1 in different sides, so you can concentrate on one which is having the symptoms and leave the other one for the future. Of course, you will explain to the patient. So before the surgery, of course, you should not forget the shot of antibiotics, ceftriaxone, after testing, and also you should have a senior endoscopic spine surgeon beside you to help if there are any kind of complication and to guide you a little bit. Always ask the side of patients and name of the patient. This is also a major mistake which will happen in the beginning. For example, left side, right side, and so on, because the patient is in general anesthesia. Control the operating nurse for any errors and mistake, because when you are starting the general, usually the operating nurse also starting this kind of surgery, it is very different, and you should control the mistakes also of the nurses also. When they're changing, for example, the saline and so on, so it should be like really sterile, so you will not have the infections, spondylitis, discitis after the surgery. So warm to body temperature, the saline, and also add adrenaline like 0.51 milligram per liter and it really helps to reduce the bleeding of the soft tissue when you're opening, and also the bone bleeding, because it will constrict the very small vessels and you will operate in clear view. So during the surgery, the priority should be, as we've said, the quality hour fast or being quicker. My first cases was 3.5 hours. For 10 to 30 cases, always do the AP and lateral views. For example, nowadays we don't use the AP views, we just go to the lateral, but first cases always you should consult both of them. And also puncture with scalpel is enough to cut the skin and the fascia for the interlaminar approach. And you should be very careful in very thin patients, because when you cut the 2 centimeter and it is already on the ligamentum flavum. So during the surgery, the major issue is when you go to the surgery, the question is how I can handle the bleeding. So of course the epinephrine solution, as we've said, and the soft tissue, you should manage this while it's small with bipolar culture. So step by step, you should use the clear view. But when you're experienced, like, you can just go on, but at the first you should stop every small bleeding. The bone bleeding, you can stop with bone wax using the dissector, very small dissector. You can put the own bone wax and place it, and also you can compress the bleeding bone with the tip of the kerosene. Uncontrollable bleeding, it is last resort. It never happened to me before, but in recent days it has happened. So you can place a obturator to the working sleeve and stop the water, stop the everything, and wait for 10 to 15 minutes. So uncontrollable bleeding, you are not having, cannot find the source. It was a patient with hemoglobin 117, which was reduced after surgery for 80. So it was very severe bleeding. We stopped this with an obturator, and patient discharged without any kind of complication after surgery, because the bleeding happened after this herniation removal. And dural tears, it is also a very important thing when consulting. Of course, you should avoid it. I had only one dural tear, but it was very interestingly we've seen this after surgery. When we were looking at the video, it was very big, but the inner layer of the dura was not damaged. So we were seeing the actual roots, but they were not herniating outside. So usually you should avoid this. If there is a dural tear less than 2 millimeters, you can just put the Surgicel and close it. But if it is a bigger, you can converge to open or ask a more experienced endoscopic spine surgeon to suture this. I have a couple of colleagues, fortunately they can fix this kind of problems also. So do not bite or cut what you don't see, of course. The post-surgery, one thing is important, that of course the antibiotics and NSAIDs, the brace for 1 month, we limit the weight lifting up to 5 kilograms next 3 months, and we restrict driving. This is very important in first months. And also, this is also very important, never do an MRI for no symptom patient, especially for example, in our country, they report this as a disc herniation when there is only annular fibrosis or posterior longitudinal ligament and so on. If mild paresthesia due to traction, you can prescribe dexamethasone for 3 days, and then you can taper this down. So, for example, this is a patient, one of my first patients. This patient is very obese, with 130 or so kilograms, L4, L5 herniation, wide base herniation, predominantly right side, with right side pain. After surgery, we removed due to traction and also increased return of blood flow. There was a paresthesia and also urinary retention. So we've prescribed the dexamethasone for 3 days. After 3 days, the patient was okay, and also the diaries also returned, so discharged completely well to home. So this was a patient. This is after surgery, like walking and so on, after 3 days. So this is the next case. It is a 34-year-old male presented with left side L4, L5 radicular pain, suffered for years. So we can see this is the cases we can pick in the beginning. So this is a patient from Tajikistan. So he returned after 1 day. So it is like next day he was walking and going home without even like letting me know. So that's it. This is the next case. This is a 45-year-old patient from Bukhara, actually from here. He came with a radicular pain in the left side. We removed. Next day he returned home without any kind of neurological deficit or anything. So this is the next cases. I think this is enough. 10 minutes passed. So thank you for your attention. Any questions and so on. Thank you.
Thank you very much. Savollarni keyin gaplashamiz, вопросы потом будет, наверное. Я хочу поблагодарить доктора Дусчанова. Хотел сказать, он является представителем клиники «Профмедсервис». Это ребята, что целая команда у них. Главным организатором, одним из главных организаторов нашей конференции является клиника «Профмедсервис». И в свое время клиника «Профмедсервис» стояла у истоков развития спинальной эндоскопической хирургии в Узбекистане. Мы сами там начинали вместе с доктором Умаровым. Надеюсь, клиника дальше будет процветать. Вчера вот мы бухарский филиал смотрели, очень красиво, и клиника